Derm pathology, common skin disorders. All right, so this is going to be the highest yield video that you will go through in dermatology, okay? This is where a lot of the questions from UWorld and other things stem from. So let's get right into it. We have acne first. Okay, so acne is caused by multifactorial issues, okay? So it's a multifactorial etiologies that cause acne. One thing they want you to know is that you have an increased level of sebum and androgen production, okay? Increased level of sebum androgen production. That's very important to know, okay? Another cause is going to be tight-fitting clothes that can cause acne, right? It's associated with androgenic steroid supplementation because, once again, it's increased levels of androgen production or sebum production, right? And what they want you to know specifically is that you will see Cutibacterium acnes, which is a bacteria that colonizes the pilosebaceous unit, okay, known as the comedones. And it causes inflammation, which kind of presents as our normal acne presentation, okay? So these Cutibacterium acnes, it causes the proliferation of them, leads to the acne presentation. And the reason behind that is because these are lipid-utilizing bacteria. So they like the lipids from the pilosebaceous units, from the comedones. And so they eat that up. They're lipid-utilizing bacteria, and they are found within the pilosebaceous units, once again. Okay? They really want you to know that acne colonizes, or Cutibacterium acnes colonizes pilosebaceous units known as comedones and utilize the lipids in order to proliferate and cause inflammation. Okay? You have to keep that in mind. All right? Next up, so that's acne, and you can use treatment like retinoids, vitamin A, isotretinoin. Those are helpful for acne. Okay? Next is going to be our atopic dermatitis. Atopic dermatitis is pruritic eruption. So it's a very itchy eruption associated with ichthyosis vulgaris and other atopic diseases. So if you see a patient with a history of asthma, allergic rhinitis, food allergies, right, they're going to have an increased risk of atopic dermatitis. That is very key. That's high yield. You have to know that. So atopic dermatitis, it's a very itchy eruption, and it has a past medical history association of atopic diseases like asthma, allergic rhinitis, and food allergies, okay? Now, what they want you to know about atopic dermatitis is that it's associated with epidural barrier dysfunction due to a filaggrin mutation, okay? Filaggrin mutation. So it's epidural barrier dysfunction due to filaggrin mutation is what causes the atopic dermatitis, which is an eruptive, itchy rash associated with atopic diseases of asthma, allergic rhinitis, and food allergies, okay? And what you'll see, it often appears on the face in infants and on flexor surfaces in adults and children. Okay. Next is allergic contact dermatitis. This is a type 4 hypersensitivity reaction. And what they want you to know is that it's secondary to contact allergens like nickel or like poison ivy. Okay. Neomycin is another cause. Okay. And what you will see is epidermal edema with eosinophilic and lymphocytic infiltrates, okay? So you will see epidermal edema with eosinophilic and lymphocytic infiltrates. And what do we know about epidural edema? Remember, the word is spongiosis. So you will see another word for that epidural edema that they will say is spongiosis. And that is an association with allergic contact dermatitis, okay? Keep all of that in mind. It's associated also with CD8 T cells and IFN gamma for the pathophysiology. All right? So before I move forward, I kind of want you to know just these three real quick, and then we'll move forward. So first off, acne is proliferation of Cutibacterium acnes, which is a lipid-utilizing bacteria that colonizes the pilosebaceous unit known as comedones and causes inflammation. It also could be caused by increase in sebum and androgen production. And then lastly, it could also be caused by increase in tight-fitting clothing, okay? Next is going to be our atopic dermatitis, which is a pruritic, itchy eruption of a rash, usually seen on the face in infants and on flexor surfaces in children and adults. Okay, so different places depending on how old you are. It has association with atopic diseases like asthma, allergic rhinitis, and food allergies. And it will see epidermal barrier dysfunction due to a filaggrin mutation. Okay, they want you to know that. Next is allergic contact dermatitis. This is a type 4 hypersensitivity associated with CD8 T cells and IFN gamma. And it's going to be secondary to contacting allergens like nickel, poison ivy, or neomycin. And what you're going to see on histology is spongiosis, which is epidermal edema, along with eosinophilic and lymphocytic infiltrate. Okay, but the spongiosis, epidermal edema is high yield for allergic contact dermatitis. Okay, let's move forward. Keratosis pilaris. What you need to know is that it's not itchy or painful. It's just follicular-based papules that are from keratin plugging, all right, and they're on extensor surfaces of the arms and thighs. If you ever see just a bunch of little dots that aren't itchy or aren't painful, just kind of over your body, over other people's bodies, very common. It's known as keratosis pilaris, okay? Next is going to be pseudofolliculitis barbae, all right? So this is just going to be a razor burn, okay? So after a patient shaves, you can see razor bumps underneath their neck. It's usually near the area that they shave underneath their neck. And it's just inflammatory reaction to the hair penetrating the skin, okay? And it's going to cause these little bumps in the area in which you shave. They are painful and they're itchy. So if you shave there, you probably know what they feel like. Pseudofolliculitis barbae, you know what that feels like, and it's more common with people that have naturally curly hair. Next is psoriasis. Psoriasis is our next high yield big one. Okay, what you need to know first off is it's papules and plaques with silvery scaling. So if you see silvery scaling, especially on our knees and elbows, that is highly associated with psoriasis. Okay, highly associated with psoriasis. You're going to see hyperkeratosis and confluent parakeratosis, right? So hyperkeratosis is going to be our increased thickness of the stratum corneum. Parakeratosis is retention of the nuclei in stratum corneum. So that's what you'll see in psoriasis. And you will see epidermal hyperplasia, okay? Epidermal hyperplasia as well. And that is known as acanthosis, which is just increase in the spinosum, okay? Increased thickness of the spinosum, all right? And the last thing you'll see is a decrease in the thickness of the stratum granulosum. Okay, so let me just run through these findings again for psoriasis. You will see hyperkeratosis, which is increased thickness of the stratum corneum. You will see acanthosis, which is increased thickness of the spinosum, also known as epidermal hyperplasia, okay? You will see decreased thickness of the stratum granulosum, and you will finally see a confluent parakeratosis, which is retention of the nuclei in the stratum corneum. Okay, so those are the four key findings: hyperkeratosis, confluent parakeratosis, epidermal hyperplasia or increase in stratum spinosum, which is known as our acanthosis, and then decrease in the stratum granulosum. Now, lastly, you have to know that there's this thing known as the Auspitz sign. Auspitz sign is just pinpoint bleeding spots that are found after some type of scraping off of the scales that are found in psoriasis. So if you see someone running into a door, they say whenever they scrape off these plaques or these scales, they notice very small pinpoint spots of blood. That is Auspitz sign, and it's highly associated with psoriasis. Okay? And remember its association with psoriatic arthritis, which we discussed previously in the rheumatology section, okay, which is one of those negative spondyloarthritis, okay, so negative spondyloarthropathies. All right, moving forward from psoriasis is going to be seborrheic keratosis. Seborrheic keratosis is going to be well-demarcated verrucous, benign squamous epithelial proliferation of immature keratinocytes with keratin-filled cysts known as horn cysts. So first off, stop everything I just said. Just take a look at the photo, all right? Look at what it looks like, and that's going to be seborrheic keratosis. And what they like to say is that it looks stuck on. Okay, it looks stuck on. That keratin-filled cyst with horn cyst, it looks like it's stuck onto the skin. Number two, associated with seborrheic keratosis, is going to be the lesser Trellat sign, which is, remember, from our gastric adenocarcinoma, right, or from our stomach cancer. It's the rapid onset of multiple seborrheic keratoses, okay, and that indicates possible malignancy. So if you see multiple of these stuck-on lesions, multiple of the seborrheic keratosis, it has its association with gastric adenocarcinoma, which is known as the lesser Trellat sign. It's just a rapid onset of all these seborrheic keratoses. All right? So remember, GI adenocarcinoma, specifically gastric adenocarcinoma. All right? So that's seborrheic keratosis. Next is verrucae. Verrucae are warts. They're caused by low-risk HPV strains. Okay, and what you want to know, they'll always say low-risk HPV is an association to verrucae, okay, for warts. And what you want to know is that it causes epidermal hyperplasia. Okay, so this is another one that causes epidermal hyperplasia, which is known as acanthosis. Okay, and lastly, And then what you want to know also about verrucae is condyloma acuminata is going to be seen on the anus or genitals, okay? And you will probably see coilocytes or coilocytosis for verrucae because it's associated with HPV. Lastly is our urticaria, which is going to be hives. It's a pruritic wheal that occurs after mast cell degeneration or degranulation, which releases histamine, okay? And it's characterized by superficial dermal edema. So superficial dermal edema is highly associated with urticaria, all right? So let's run through, what I want to run through is the microscopic findings for each one of these diseases so you can have an association for it. All right, so the first one I want to discuss is going to be our allergic contact dermatitis. Allergic contact dermatitis is going to present with epidermal edema. And remember, epidermal edema is known as spongiosis. Next is going to be psoriasis, which has hyperkeratosis. And all that is, remember what all that is going to be increased thickness of the stratum corneum. It has confluent parakeratosis, which is retention of nuclei in the stratum corneum. It has acanthosis, which is epidermal hyperplasia or hyperplasia of the stratum spinosum. And it has a decrease in the stratum granulosum. All right. Moving on, you have our verrucae. Our verrucae has epidermal hyperplasia as well, which is going to be known as acanthosis. And then lastly, we have our urticaria, which is superficial dermal edema. So it is not spongiosis because it's not epidermal edema. It's just known as superficial dermal edema. There's no name for it. Okay, so hopefully that's going to be very, very helpful for you to kind of differentiate each and every one of these common skin disorders. This is a very high yield page. Once again, the ones that I focused on are probably the highest yield stuff. Remember the differentiation between atopic dermatitis and allergic contact dermatitis. Acne is pretty straightforward. Psoriasis is very high yield, and seborrheic keratosis followed by verrucae and urticaria are relatively lower on the list of high yieldness, but still are very important.